and all the states then can follow the national standard, and it would have been nice if there was funding that went along with it. But this will happen in other parts of the country.
This is a presentation for AP621.
Wherever you have density and gatherings, and it only takes one, the rule of one.
Cerebral blood flow abnormalities.
Speak again, whether it's sometimes 75 days from now.
The patient presentation. The patient is a 37-year-old female presented to the ED with complaints of cough, headache, chills for the last week. She developed progressive dysarthria with numbness and weakness to the left arm and leg for the previous 28 hours. Her delay in seeking emergency medical attention was related to her fear of COVID-19, which within the ED. At the time of admission, her NIHSS score was 19, where this is the National Institute of Health stroke scale to determine the severity of the presentation of the stroke and the outcome. Her score ranged 19, and the range is 0 to 42, where 42 is maximum severity. Her review of system is noted as above. Her physical exam, her general appearance, she's awake, alert, oriented, anxious, well-nourished, well-developed, and appears stated age. Her HEENT, she had bilateral injected conjunctivitis. EOMs are intact, and pupils are equal and round, reactive to light with tonsillar erythema. Cardiovascular is regular rate rhythm, S1, S2 within normal limits, seronegative murmur or gallop, negative carotid bruit or JVD. Lungs are clear to auscultation, non-labor, bilateral chest expansion, abdomen is benign with active bowel sounds and normal bowel pattern. GU, volitional voiding and negative dysuria. Integument is negative rashes, lesions, or petechiae. Her neural exam is that she is oriented ×4, but she is having some dysarthria with left hemisensory loss and paresthesia and left hemiplegia. The differential diagnosis is cardioembolic stroke, cerebral atherosclerosis, cervical cephalic arterial dissection, moya-moya disease, hypercoagulable condition, genetic conditions such as neurofibromatosis, inflammatory vasculitis, and infectious process such as neurocysticercosis. Laboratory findings, chemistry, and complete blood count were all within normal limits. Her serology was negative for anticoagulant, ANA, antiphospholipid, RPR, VDRL, but she was positive for SARS-CoV-2 antibodies. Imaging, CT head non-contrast showing partial infarction of right middle cerebral artery territory with a partially occlusive thrombus in the right carotid artery at the cervical-carotid bifurcation. CT angiography of the chest revealed patchy ground glass opacities in the bilateral apices. Echocardiogram was negative for thrombus or valvular dysfunction and no evidence of valvular vegetation. MRI, MRA, head and neck showed right middle cerebral artery infarct and partial occlusion of the right carotid artery.
Or visit SeasonsMalibu.com.
This is some imaging showing the infarction on a T2.
Even if no one in your home smokes,
MRI imaging. As you can see that there's quite a bit of infarction noted. The pathophysiology.
non-smokers.
The consensus that this is a COVID-19 related coagulopathy and has been termed a sepsis-induced coagulopathy, which is abbreviated SIS. This is fairly new since the COVID epidemic. It is marked by epithelial dysfunction and microthrombosis with organ failure without bleeding. Thrombus formation most likely occurred in the lungs, as evident by the patchy ground opacities, indicating massive pulmonary tissue destruction observed on chest CT. Microvascular thrombus formation traveling from the pulmonary artery, seeding upstream, lodging at points of bifurcation in the carotid artery. This process further occludes the middle cerebral artery, causing ischemia and cerebral infarction.
That's a very, very bad thing.
The final diagnosis is right middle cerebral artery infarction, right carotid artery partial occlusion. The management, the patient was admitted to stroke unit, permissive hypertension to maintain an MAP of greater than 65 millimeters, head of bed 30 degrees, antiplatelet therapy until imaging completed. Once imaging confirmed diagnosis, the patient was placed on full anticoagulation with a goal of a PT-INR of 2 to 3. Anticoagulation planned for 3 to 6 months. A patient was also monitored for pneumococcal deficits, and within 2 weeks of discharge, the patient was within 2 weeks of admission, the patient was discharged without any further complication to acute rehab program.
That last installment expecting is on, quote,
Summary. Strokes occurring in young adults is a major public health problem. COVID-19 is now observed to exacerbate risk of ischemic event. Early data is showing. There appears to be vascular injury within the epithelial surfaces of the arterial vessels, and this injury acts as a nexus to thrombus formation. Early intervention and management are crucial to diminish the long-term disability associated with cerebral or vascular large vessel occlusion and the economic burden. When an individual has a stroke in the 4th and 5th decades of life, the requirement for health care and long-term care is much greater than a person experiencing a stroke later in life. The full understanding of the implication of COVID-19 as it relates to strokes in young adults and specific diagnostics and classification criteria requires still more comprehensive epidemiological representation. Somajit in 2015 concluded that there is a need for more robust primary and secondary prevention of strokes in young adults. And this concludes my presentation for Module 9. Thank you.
Shoot the breeze instead.
Does it say this thing's a killer?